Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. I want to thank you for coming on to the show. Today's topic is about Ask Me Anything, and you're welcome to ask me anything. The way to do that is to type your questions into the chat pad, or I can get you live on the show by sending you a link. You don't need to go on camera if you don't want to, but it's great if you can. You can just talk. But, that's the way the show is laid out. If you don't have any questions and you just want to listen in, I have a large number of emails that are coming in with questions. So I will just answer the questions that have come in via email during the week, and and I will read them out. But in the meantime, feel free to type your questions into the chat pad, or if you want to come on live on the show, please type it into the chat pad and I will send you the link, and then I can get you live on the show. Now, before I do answer today's questions, a little bit about myself. What makes me qualified to answer any questions that families in intensive care have? I am a critical care nurse by background. I have worked in critical care for over 20 years in 3 different countries, where I have also worked as a nurse unit manager for over 5 years. I have been consulting and advocating for families in intensive care for over 10 years all over the world, as part of my intensivecarehotline.com consulting and advocacy service for families in intensive care. I am also the founder and managing director of Intensive Care at Home. We are operating a service, Intensive Care at Home, in Australia, all around the country. We are NDIS, TAC, iCare, NIISQ, and DVA approved community nursing service provider in Australia. So, we are providing a genuine alternative to a long-term stay in intensive care with Intensive Care at Home. And you can find more information at intensivecareathome.com. Now, I've got the first question here from Mary, who says, wanted to ask how we can ask the ICU to keep our loved ones longer rather than sending to long-term care. Sure. Thanks, Mary, for that question. Can you share a little bit more about how many days, weeks your loved one has been in ICU for? Can you please share that? And also why they're in ICU. And my answer will depend on, how long they've been in ICU for. That's the first question that I would like to have answered. The next question is, do they have a tracheostomy and a PEG tube already? And the third question is, what is their condition? If you can answer those questions, then I'll have, I believe, a succinct answer for you how you can keep them in ICU for longer. In the meantime, Mary, while I'm waiting for your questions, I'm going to the emails that have come in during the week, and I'll start answering some of them. Okay, let me just get to my emails and answer those questions. So the first question that has come in this week is from Andrew. Andrew asks, my sister is 30 years of age and has been in the ICU for 7 days, fighting for her life on life support on coma with meningitis. Her brain is obviously swollen, but it's unique and swollen on the inside as well. 2 CT scans have been done on the brain and showing no improvement. However, the doctors aren't saying much. Why is this? EEG for seizures shows active seizures, but haven't really said too much about the other brain scan results. Not really saying much about the recovery either. Right, okay. So Andrew, that sounds like it's a tricky situation, but not an impossible situation either. So if your sister is in ICU with meningitis, the first question that I have is, has she had a lumbar puncture, right? Have they found, is it a bacterial or a viral meningitis? If yes, if they found the cause of the meningitis, how are they treating it? If she's having seizures, are they giving anti-seizure medications, right? And what are those seizure medication, anti-seizure medications? You haven't shared whether your sister is, you're saying she's on life support, so she must be on a ventilator in a coma. If she's in a coma, what's keeping her in the coma? Is it the meningitis, or is it the anti-seizure medication, or is it the sedation and the opiates? Sedation and opiates are often given for tolerance of the breathing tube, right? So what is the reason for that? Now, 2 scans have been done on the brain and showing no improvement. It's been 7 days. The doctors aren't saying much. Well, here is my response to that. If the doctors aren't saying much, you haven't asked the right questions. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And if you knew how to manage them, you would have all the answers by now. When it comes to asking questions in intensive care, you really need to drill down to the nitty-gritty, to the detail, right? You can't just be scratching on the surface. When someone is in intensive care, like your sister, there are dozens, potentially hundreds of things happening simultaneously. And unless you have an understanding of piecing together the puzzle, you will fight an uphill battle, which is what I believe you are experiencing at the moment. You haven't worked out how to manage doctors and nurses in intensive care, right? They're not saying much because you haven't asked the right questions. That is why. So I have given you some hints what questions to ask. Why are they not saying much about the recovery? Look, it is very difficult to predict outcomes in intensive care. However, here is what the statistics say. The statistics say that approximately 90% of intensive care patients survive. That's 9 out of 10 surviving. So why would your sister be the 1 out of 10 not surviving, especially at such a young age? Right? Your sister is 30. So that stands in her favor. And if the brain is swollen, other questions are, does she have a midline shift? How severely is it swollen? Is the midline shifting by millimeters, centimeters? Is it not shifting at all? And And you're saying brain is obviously swollen, but it's unique and swollen on the inside as well. Well, the brain can really only swell on the inside. It can't swell on the outside, you know. So that is what I would be focusing on. Now, the best way for me to help really is by talking to doctors and nurses directly, by looking at medical records, you know, by doing a combination of both. You know, by doing a combination of both. You know, that's really how I can leverage your input. And, you know, the reality is the families that get the best outcomes in intensive care for their loved ones are the ones who go all in. You know, who go all in, who get a second opinion, who get help, and are fully committed to a good outcome, right? They get the best results. If you're half-hearted about getting help, you're not getting the outcomes that you want, or you will be seeking help when it's too late. A lot of families come to us when it's too late. So, Andrew, I hope that answers your questions. I also would want to know, you know, what ventilator settings is your sister on, right? What sedatives is she on? What are the blood results showing? What are the arterial blood gases showing? What medications is she on? You know, I would want to see the CT scans in detail and the MRI scans of the brain in detail. That's how I can piece together the full picture and the puzzle. Okay, Mary, you responded here. So your family member is 16 days in ICU, went to LTAC for a few days, had an infection, so they had to send him back to ICU. He was there for 6 days and then again transferred him back to LTAC. He has a PEC and a tracheostomy. Okay. Okay. All right. What condition, why is your loved one in intensive care / LTAC to begin with? Right. Why? Can you share that with me? Mary, it might be quicker if you want to get on the show here. Don't know. I know some people, they don't want to come on the show. Let me know if you want to come on the show. I'll post the link here anyway. You can just use that link that I'm posting here now. I think I can help you the quickest if I can actually talk to you. You could just use this link that I'm just posting here. You can do that. You don't need to go on camera. That would be the quickest way to help you with this. If not, I'll wait for your responses. So why did he go into ICU in the first place? You said he's had an infection. Yeah, sure. I mean, LTACs can't manage an infection. They can't manage anything. That's why people bounce back into ICU. So, you know, hang on, I'll just post that stream again. What is the underlying condition, Mary? Why did your family member go into ICU in the first place? I understand he had an infection now that he went into LTAC, you know, but the more information you can give me, the better it is. Now, I would imagine if he's been in ICU for 16 days, if he's been in ICU for 16 days, I would imagine that, you know, he had a tracheostomy and then he went on to LTAC. You know, that was just about the time. Mama, I can see you're in the waiting room. Let me just answer this question and then I'll get you in. So it's been in ICU for 16 days. Then he went to LTAC for a few days and he had an infection, so I had to send him back into ICU. Well, the problem here is he should have never gone into LTAC in the first place, you know. Should have never gone. And it simply comes down to families standing their ground. It's as simple as that. And another option here would have been not to give consent to a PEC tube. No need for a PEC tube. And as long as patients don't have a PEC tube, they can't go to LTAC because LTACs won't take them. Right? So that is my short answer to them. An ICU cannot discharge a patient to LTAC if you don't give consent. It's as simple as that. If you have anything to add, Mary, please let me know. Mama, I'll get you in now. Just give me 1 second. Can you hear me okay?
Yeah, I can hear you well. Hey.
Hey, how are you?
Hey. This is Mary, and like you call me
Yes,
Mary,
yes.
but
Mary, sorry, no, no. Oh, is it you that's posted the questions?
yeah, yeah, that's me.
Oh, it comes up as okay. I didn't realize it's the same person. Sorry about that.
Mm, that's fine. So actually, I'm part of your like
Yes, yes, yeah,
membership.
remember, yeah.
Yeah, but they asked. I'm still waiting to get the medical records, so I didn't have all the details. But about like not giving them I mean your approval to do the trek and peg, like it was almost after 14 days. Like, isn't it like after 14 days, like the ventilator itself can cause some issues? Like,
It can, it can. There is a reason why one says, a tracheostomy should be done day 10, between day 10 and day 14,
mhm.
right? There's a reason for that. What I will say is this: what if you're at the day 10, day 14 mark, and maybe your brother or anyone just needs a couple of days and then they can avoid the tracheostomy and can come off the ventilator? That's when a second opinion is coming in so handy. You know,
Mhm.
did did you know that when you gave consent to a trach and a PEC, did you know that they were planning to send him to LTAC, or was that sort of,
No,
did
we did.
they
I didn't know.
almost like bait and switch?
Yeah.
That's terrible.
And I didn't know even keeping him in the ICU is an option. I thought like generally the rule of thumb is like after doing this, they will send him to the long-term care for all the patients.
What I will do, Mama, is I will send you a document that we have from a lawyer that will clearly highlight that, if you don't give consent,
Hmm.
your family member won't go anywhere, right? With the exception, of course, if someone is ready to go home, because they're well enough, of course, then you have no leg to stand on. But, the clients that we are dealing with, they're all very complex.
Yeah.
you
Okay.
know the I'll send you that. The other question that I have is, um, the hospital has not told you there are issues with insurance. Insurance won't pay any longer for ICU. There was no issue around that.
He is on Medicaid, so definitely he has one of the best insurances that someone can have. So I don't think that was an issue.
Yeah, so the ICU has not told you, oh, the insurance contacted us saying, oh, he's no longer entitled for ICU. There
No,
was none of that.
no,
And you haven't been contacted by the insurance.
no.
Yeah. Yeah, that's the other exception, that if insurance contacts you or the power of attorney and says, hey, look, we're running out of entitlements here, that there is another loophole there for the hospitals. But if that's not the case, then you know I I'd say there's nothing to worry about. Now the other question that I have: so he went to LTAC for a few days, he had an infection, so they sent him back to ICU. Did he go back to the same ICU that he came from?
No, it was under the same hospital, like but different branches, different campuses.
So basically, they send him back to another ICU, even though it's the same hospital chain or whatever. But basically, a new team. They didn't know him.
Yeah.
That that's terrible. That's shocking to hear. And right now, he is back in LTAC,
Yes.
same LTAC than he went to in the first place.
Yes. Yes.
And obviously, you have concerns already, given that he bounced last time.
Yes, especially that last time that, as you know, like we are in two different cities, but when I video call with him, saw that his eyes are going in circles, like clockwise and counterclockwise, and that was really like sad to see. So I'm not sure like how is that treatment going.
What is the treatment?
I know that he's not on any sedations anymore, according to the doctors, and they are trying to wean him off the ventilator, but like they were not successful. But I'm not sure about all the details of the rest of the treatment. But about the eyes, they told me that because of the severity of the brain damage, probably that's the way he's going to be.
So, okay, do you know whether A, there is specific rehabilitation plan for his neurology, for his neurological condition?
No.
You don't know, or you say no, that's not planned, or you don't know?
Oh no, I don't know. I talked to the doctor. He told me first of all there is no that like any of the score that you asked me, the glaucoma
Glasgow,
score, like he
Glasgow.
said like he hasn't calculated that. But he told me like although he's not in sedated anymore, but he cannot move his arms, legs, the severity of the brain damage. So I know about those things, but I don't know more than that.
When was the last time you've seen your brother?
About 10 days ago.
Okay. Was he opening eyes?
He was opening, but he was not really, it was like going to like look at the ceiling, it seems.
Okay. If you asked him to squeeze your hand, would he squeeze your hand?
No, there was never any signs of he understanding me.
Right. Okay. Okay. Do you know what the latest brain scan showed, whether it's an MRI scan or the CT scan? Have you seen a report?
No, I asked to get the medical records. I'm not sure they are going to share, but I mean, that's in the process. But the doctor told me there were two different MRIs and EEGs, but like it doesn't show any improvements. The same way as the other guy was asking you. Like this in this case, it seems there was no changes either.
Okay. If how many days ago did he have the tracheostomy?
On October 19th, so 15 days ago.
15 days. Okay. He should no longer be on any sedation. You know, one of the reasons you do, or one of the main reasons you do a tracheostomy is simply so you can eliminate sedation. Right? That is one of the main reasons somebody has a tracheostomy. So if they're telling you he's on sedation, I do believe they're missing the whole point of.
No, he's not. From
He's
three
not.
days
Good,
ago,
good,
he's
good,
not.
good, good. Okay, good, good. Okay, great. Okay, so then with the infection that pushed him back into ICU to begin with, that infection is cleared.
Yes.
And that was what kind of infection? Chest infection, urinary infection, do you know?
Chest infection.
Chest, okay. And when he goes into LTAC, are they mobilizing him? Are they doing physical therapy? What are they doing? Do you know?
About mobilizing, they said like I think what I understood, the bed has something that does the movement for him. It's not like they are really mobilizing.
The bed cannot replace someone doing physical therapy with him.
So if someone is not replying to anything and not following commands, can they still do physical therapy?
Nothing stopping anybody from doing movements with someone's hands, arms. Nothing stopping from the team there getting your brother in a recliner chair, in a special chair. The only thing that's stopping them is a complacency or laziness, right?
Mm-hmm.
And I'm sure that when your brother was in ICU, they would have, quote unquote, sold you on LTAC because he's getting rehabilitation there and he's getting weaned off the ventilator. Isn't that what they told you in ICU?
Yeah.
Yeah. And you can see none of it. Is that fair to say? You can see none of what they promised you.
Yes, but is it that's something that I can ask? Like they cannot
One.
tell me that because he's not like doing anything, we cannot work on his physical therapy.
Okay. So let me ask you this. If you want to run a marathon, can you run a marathon by lying in bed all day?
No.
If you want to get better, can you get better by lying in bed all day?
No.
The only thing that stops people from mobilizing is if someone has a fracture, if they're waiting for surgery. But that doesn't seem to be the case in your brother's situation.
No, there's
So
none.
I have not seen, in all these years, Mama, I have not seen anybody getting better by lying in bed all day. And if they have a brain injury, the only way you can get better is by gently increasing, how you stimulate them. I'm not suggesting get them out of bed every day for 12 hours. You have to start slowly, gently, but you have to start somewhere. And especially with him going into LTAC and then bouncing back with a chest infection, that's a clear sign to me that by them not doing physical therapy, that by them not mobilizing him, it's a clear sign to me that this will happen again. The definition of insanity is doing the same thing over and over again, expecting a different result. If you look at patients who develop pneumonias on a ventilator, whether it's in ICU or in LTAC, it's usually the patients that don't get mobilized.
Okay. So I'll
Right?
definitely ask.
And here is another issue that I can foresee, Mama, is so when patients go from ICU to LTAC, they're often on a timer. So what I mean by that is, they're often given a 30-day window. It depends a little bit from state to state, from my experience, but they're often on a 30-day window. And if they can't be weaned off or don't make any progress within that 30-day window, they do another bait and switch with you. And a few days before the 30 days are up, they're saying, oh, he's not improving. Now he needs to go to a skilled nursing facility.
Actually,
So
in our case, it was even worse. They said, like, if he's not improving, they have to send it to hospice.
even worse. So then, with all of that said, then why would they not try? Right? Why would they not try? It sounds to me, and it sounds horrible what I'm saying now, but it sounds to me like they've given up, like they've written him off. That's what it sounds to me like. I'm not there, obviously, but just by what you're sharing with me, it's like it's too hard for them. That's what I'm hearing.
Yeah, from every time I called and I talked to the nurse, it's the same sentence. Like, he hasn't changed. It's the same as yesterday, but they are not sharing more than that. So I have to ask, especially that yesterday I received the email from your team, so at least I have more questions to ask. But like, they don't share more than that.
You know why he hasn't changed? Because they haven't changed. They're still doing nothing, by the sounds of it.
Okay, so in your experience, when the eye movement is as crazy as I told you, you saw that people still trying to like mobilize the patient and do therapy.
100%.
Uh-huh.
100%. And like I said, they have to start slowly, because the risk for your brother might be that he might be experiencing seizures. You don't want that. That would be a setback, right? But what needs to happen is you need to start somewhere, and that might be by doing range of motions in the bed, like moving hands, moving arms. That would be a starting point. The next sort of escalation from there would be to get him in a chair. There are special chairs in ICU or in LTAC, like tilt tables. For example, you don't need to, you can just slide over a patient onto a chair. The chair is flat, and then you put it in a seating position. There are ways to do that, and they may have to start with 5 or 10 minutes getting him out of bed, see how he reacts to that. If he can tolerate it. Of course, you have to stop if he can't tolerate it. But it sounds to me like he's unconscious to the point where, he may be tolerant to sitting in a chair. Or are you concerned that he may not be able to tolerate it?
That's not my concern. Like, they need to tell me like what's the main concern is.
Yeah.
But
I don't think.
who is the right person to ask? Because I usually call when he's in LTAC. The point of contact for me is the case manager, but generally, who should know about these details and plans?
Yeah, the people who should know about these details is the nurse in charge, or the nurse that's allocated to look after your brother on a shift, right? But the person that should also know about it is the physical therapist working with your brother, right? There would be a team of physical therapists, I would hope, right? And obviously, this also needs to be driven from a medical point of view. Needs to be driven from the doctors. The question here is, in LTAC, one of the issues that we're seeing in LTAC all the time is: is there even medical oversight? Are there doctors? Do you know?
Yeah, this actually, he is in this LTAC because 2 years ago, same brother was sick with COVID. Like he was very sick with COVID at that time, and actually he went from ICU to this LTAC, and he got much better. So I
Okay,
saw there was physical therapists, and like they really helped him during that time.
right. So you actually have a good experience in that LTAC.
Yeah, yeah, I've been there. I saw like they were. So the ratio of nurse to patient was exactly like not that great, but other than that, I saw the doctors coming, going, and like taking care of the
Okay,
patient.
that's good. That's good. So the difference this time is that he's not responding, whereas last time his brain was working.
Yeah,
So
yeah.
that's the difference. But I like what I've seen when people improve over the years is when people are proactive with them. And when it comes to recovery from brain injuries, from what I've seen, it takes a long time. But the longer you wait, the more difficult it gets. There's also another issue here, Mama. If they're not moving him, he will end up with contractions. His limbs will contract. Does that make sense?
Yeah, yeah.
Every day counts. Every day counts. We're having another client at the moment that we're working with. He has been in ICU now for a few months. Kind of a similar situation. The only difference is he's been there for much longer than your brother has. And they haven't mobilized him. And now he's ended up with a pneumonia. And I go like, well, I'm not surprised because he's been lying in bed for months. Right? A good ICU will mobilize patients, or a good LTAC will mobilize patients. When your brother was in this specific LTAC last time, they would have been proactive. They would have mobilized him. They would have progressed things further.
Yeah, at that time, I should mention that like he was able to, he could look at you. I mean, the face was working, but like anything under the neck, like the first few days wasn't do anything. Like the hands, arms, I mean legs, like they were not moving at all. So at that time, yeah, they were working on him and it was successful.
Right. Right. The same needs to happen now. Now, the baseline is obviously different this time.
Yeah.
And, and of course, what I can't tell you here is there are no guarantees that, despite best efforts, that your brother will improve. There are no guarantees for that. But one thing is for sure: if they're not trying, you know the outcome if they're not trying.
Got it. Okay.
It takes a lot of work, a lot of patience, a lot of nurturing. It's hard work mobilizing patients. Don't get me wrong, it's hard work. And I'm a bit more old school. I did my training through nursing school. I never went to university for the nursing side of things. I'm very old school in that aspect. The first thing you get drilled into nursing school is, well, mobilize your patients. And I do believe there is now a different generation of nurses coming through and physios, and they think they can do it with hands off. No, it's not happening with being hands off. It's
So
only
you were mobilizing patients who were not following any commands.
we were mobilizing. There was one ICU that I worked in. We were mobilizing patients into chairs with breathing tubes to avoid a tracheostomy in the first place, right? And they were often in comas. Now, why would we mobilize them even if they were in comas? Because you would sit them up and that would help them with breathing. That would help them preventing pneumonias, preventing all the nasty stuff that you get by not being mobilized. This was hard work. It has to be safe. You got to get a chair ready. You need 5 people to transfer a patient from the bed over to a chair, right?
Yeah.
But we had, this is hard work, hands on, but it works, and in your brother's case, it might be slightly different in terms of that they have to go slow because he does have a brain injury. I'm not saying rushing things. That's not what I'm suggesting. But you have to start somewhere, and you have to gauge, can he tolerate 10 minutes in a chair? If he can't, okay, maybe he does need to rest. But if he can we do 20 minutes tomorrow? Okay. If he tolerates that, can we do 30 minutes tomorrow? It'll be important. You don't want to mobilize patients if they end up with seizures, but it sounds to me like currently there are no seizures.
No, it seems like he's very stable, but other than being stable, there's nothing else.
Right. Stable. I like that. He's stable. That is a good starting point, I believe, to take the next steps.
Okay. Patrik, I know I asked many questions, but can I ask one quick question?
Please keep going.
So, in your experience, have you seen like stimulating the brain of a patient who is not responding to anything can help? Like I usually video call with him, ask someone to take the video there and video call, like play music and talk to him. But it's more like definitely like I'm the only one talking. So I'm not sure in this case, have you seen, especially right now that there is no sedation? Do you think that can help?
Oh, absolutely.
Mhm.
Absolutely, Mama. Look, there are patients that are coming out of comas in intensive care that will tell you, I don't remember the details, but I do remember my family talking to me. Now, the opposite is true also, that patients come out of situations like that and they don't remember a single thing, right? So it's not a one size fits all. Different patients report, different experiences. But I do believe that having families either present, or even if it's only virtual and you're talking to them like we talk here virtually, I still believe that's better than
Nothing.
not talking to them at all.
Yeah.
If you look at research out there, there's plenty of research papers out there from ICUs who says, well, family presence helps with recovery of loved ones. And of course there are no guarantees, but I do believe, imagine you're waking up or you're semi-awake in an ICU. It's like waking up in a horror movie, really. And you have no familiar voices around you, no voice that you can recognize, no one comforting you. Yes, I would hope that the nurses or whoever's working with him will comfort him, but I do believe that family presence is
The key.
crucial, key.
Okay. I appreciate it and thank you so much for the time.
It's a great pleasure. Anytime.
Thank you. Thank you.
Thank you. Okay, Helen, I can see you're here now as well. You're saying there are some hospital beds that can also transform into a chair. Yeah, for sure. But that you are right, and that is the first step that should happen. However, from my experience, it's nowhere near as good as actively mobilizing someone. Again, the hospital beds that can transform into a chair, that's good for patients that can't be mobilized because they have fractures, they're awaiting surgery. Absolutely, that's sort of the next best thing to not mobilizing. But I'm a big believer that you can't beat mobilization. And you are also saying you played music that my mom enjoyed, helped her come out of the coma. Yeah. no question that whatever level of familiarity you can bring to your family member is crucial. Whether it's playing music, whether it's talking to them, like I said, imagine you're waking up in ICU, you've got tubes coming out of you, you've got a tracheostomy or whatever, you've got a breathing tube in your mouth, you can't talk, you can't express yourself, you have no recollection often of what's happened, why you're there, like waking up in a horror show, really. And the only people that can really comfort patients often, of course, I would hope that my nurse colleagues will do that, but it doesn't replace having family there, from my experience. Okay, so I know there are other viewers here now as well. If anyone wants to come on the show and ask questions, just click on the link there, the StreamYard link. If not, I'll just continue with reading out questions that came in during the week. And Helen, you're saying your mom responded to your voice when she came out of a coma. Yeah, for sure. There's, you would have heard all that during COVID, most hospitals, well, pretty much all hospitals all around the world were locking out families. There were no visitors during COVID in ICU. And, many patients died. And I believe that part of that might have also been because there was no family support, and in my experience, that would have been detrimental to patient recovery. All right, so let me read out another question here from Anthony, who says, "Hi Patrik, I'm reaching out about my dad, who's currently in a minimally conscious state after battling pneumonia. He was discharged from ICU at Kaiser Permanente a week ago. Shockingly, the hospital is refusing essential life-saving care, such as CPR, antibiotics, and blood pressure support. They've even rejected the possibility of ICU readmission if his condition worsens. We strongly believe these actions violate his rights under the EMTALA. Can you help us navigate this situation?" Yeah, that's an easy one, Anthony. And most Kaiser hospitals are in California. And I know the one that you've mentioned here is in California. I didn't want to mention the location. But in California, it's as simple as that. If you want full treatment for your father or for any family member, if you want full CPR, antibiotics, blood pressure medications, you are well within your rights to do so, right? So when you look, you type into Google like patients' rights in California or end of life decision making in California, you will get a whole library of, confirming what I'm saying here, that it is you, the power of attorney, that's making the call and not the hospital, right? By them not offering CPR, they're breaking the law, right? And the reason I'm saying that so confidently is we have helped so many families over the years, with exactly those very questions, where we go back to them and say, look, here's the evidence, for what we're saying. Again, there's a whole library online, when you type in like CPR or DNR laws in California, you will see it is up to you and up to you only when, to perform CPR. It's not up to the hospital. And the same with giving antibiotics, blood pressure support, they're rejecting the possibility of an ICU readmission if his condition worsens. It's not up to them. It's not up to the hospital. It's up to you to say what you want, assuming your dad doesn't have an advanced care plan. That's the other question. Does your dad have an advanced care plan, right? If your dad has an advanced care plan and it says, well, I want everything to be done in a, if ever I get critically ill, then it's black and white. But even if it's not black and white, you as the power of attorney are in charge of what you want done. Now, here is the thing that I've noticed, over the long time that I've worked in ICU and now with the work that I'm doing now. Hospitals are extremely good at pretending they can do whatever they want. They are extremely good at pretending they are operating in a vacuum. So what do I mean by that? So by the hospital saying, oh, well, we won't do CPR, we won't give antibiotics, we won't give blood pressure medications if he needs it, we won't do ICU readmission if he needs it. I mean, that could be perceived as negligent, right? If your dad was to pass away because they're withholding life-saving treatment, that could be perceived as murder, euthanasia, right? Just putting that out there. However, when we talk to doctors or when I talk to doctors and nurses directly and remind them of their duty, we've never lost a case. They just need someone that speaks their language and that knows the landscape of intensive care. And they just need to be reminded of that this could be a lawsuit, and usually they back off. I think for now, they're trying to walk all over you, Anthony, and you just need to arm yourself with the right information, put it in front of their faces and see what happens, and you will see that the situation changes pretty quickly. Right? They're just trying to get away with as little as possible. ICU beds are in high demand. They probably don't have any bed for your dad, which is why they're trying to put in place what they're trying to put in place. They probably think, even if your dad was to get better, if he was to survive, in their eyes, he won't have any quote unquote quality of life. There's a whole number of things, but it's also about control and power. And, it's also about, I believe it's about population control. Right? It's about population control, and and you need to stand your ground. Just by you standing your ground, I strongly recommend that on all levels. Don't let anyone walk all over you. Just by you doing that, you will often see a change in demeanor, and you will often see a change in behavior, and you will often see a change in outcomes. So do that, Anthony, and then you will see that things will change. Okay, let's move along to the next question here. From Nancy, who says, this is actually a comment that she sent. She says, as long as my loved one's heart pumps blood and he breathes on his own, he's alive. Just because one doesn't operate the way we think and believe, they should. And it doesn't mean to give into the brain death theory. Is that accurate? Well, that is a good question, and it's not as simple as a yes or no. I think there's many nuances to that. So let me read this out again. As long as my loved one's heart pumps blood and he breathes on his own, he's alive. Just because one doesn't operate the way we think and believe they should, it doesn't mean to give into the brain death theory. Well, here's my take on that, Nancy. I have my own personal spiritual, religious beliefs, and it really depends on what what your personal beliefs are. Now, doctors may test for brain death, and they may come to the conclusion that someone is brain dead. That doesn't mean you need to agree with it. Now, case in point, in most countries around the world, especially in the English-speaking world, when someone is declared brain dead by two independent parties after they've gone through brain death testing, right, they're often legally dead. Legally. However, there has been a case about 10 years ago in 2013 in California, a young girl, J.I. McMahon. J.I. McMahon was a 13-year-old girl who had a tonsillectomy, and after the tonsillectomy, she had a massive bleed in her throat. She ended up in cardiac arrest, and she was declared brain dead after the cardiac arrest. Now, the family challenged that. They went to the courts. They wanted a tracheostomy. They wanted to keep her alive. And the courts decided that, the hospital needs to back off and needs to give the family an opportunity to resolve this amicably. and the family transferred her to New Jersey, because in New Jersey, someone that's declared brain dead is not considered legally dead, right? And they moved her to New Jersey with a tracheostomy, with a breathing tube, and she lived there for years to come. And there are videos out there. If you type in J.R. McMahon, you will find more information. So, Helen, I can see you're here. I'll let you in. I don't have a lot of time. I usually wrap out at the hour, but I'll let you in, and then you can ask your questions. I have another 5 minutes.
Okay.
Sorry, Helen. Nice to see you again. How can I help you?
Okay, I'm going to go back on a statement you made earlier about pressors. Um, as you know, my mother has passed, but at one hospital, I found it very strange that when they were trying to put her on the correct pressor, which I still didn't, nobody was telling me anything. They couldn't get the right blood to match whatever to know what pressors to put her on. And I found out that some of the nurses were straight out of nursing school working in ICU. And I noticed a skilled nurse, she would throw away the first set of blood and then use that second tube, where the untrained nurses used the first tube. And it took forever for them to get her the right pressor, get her where they can put her on a pressor. And also it caused her to have hemoglobin. I think she needed a blood transfusion. I mean, and as you know, my mom also suffered from iatrogenic induced brain injury. Um, and it just floored me that everything they did to her was, to me, considered at the level of torture, because they induced all of this while she was in the hospital. But when I was talking about the knowing how to get the right blood where it can match up, and it took me bringing it to their attention to say, I noticed when her blood is drawn by certain nurses, and when there's another set of nurses who I knew was straight out of nursing school working in ICU, it wasn't matching up. And I said, but they will use the second tube. So would you like to make a comment about that? You have to.
Look, what can I say about this? I do remember my first few weeks, months in ICU. Very challenging, and there's no way that even after 2 years I would have had the level of knowledge that I have now, right? And as much as ICUs go through training, retraining and all of that, there's always room for error, always room for human error in particular. Now, you know what? If I have to sum up my 20 years in ICU, sort of the issues that I've seen, and the biggest issues in ICU comes down to staffing issues, right? The turnover of senior nurses is high. They're burned out, so they're leaving. And what do you do then? You train the next generation of nurses, but in the meantime, you're losing all this intellectual property from senior nurses because they're burned out and they're moving on to the next thing, right? And then you start from scratch, training someone like you've just described, training them out of nursing school, and then you have an ICU full of junior nurses. I've seen it over and over again. And that's also when the senior nurses are leaving, because they're under the pump training junior nurses. That's why they burn out. It's a vicious cycle. And I know with your mom, that was way before COVID. Imagine what it looks like now after COVID with, it's mayhem, absolute mayhem. So I don't have, I can only describe to you what I've seen over the decades. And that's
It was
not
a
going to
horror
stop. It has
story.
become horror show.
Yeah.
Getting
It was
worse.
like a nightmare. Pardon me?
And it's
I'm
getting
sorry,
worse.
Patrick. Oh my God. God help us.
Yeah.
Because it was a nightmare I couldn't wake up from. And like I would say, even a blind bat can see what was going on. It was that horrific.
You know what they
amazing.
did during COVID? During COVID, they were basically pulling junior nurses off the ward or off the floor somewhere and putting them into ICU because of staff shortages with no proper training. You know, outside of COVID, at least there were training programs. Now, during COVID, there were crash course training programs.
First, back in 2012, ended up in ICU. They had nurses coming from the maternity ward into ICU. It's like, what? But I'm not going to take much more of your time, but yeah.
No, I do need to wrap this up today.
Yep, thank you.
No, thank you. Thank you for your contribution. Thank you.
You're welcome.
Okay, so thank you everyone for contributing, Mama and Helene, with your questions. I do need to wrap this up for today. I do these YouTube lives usually every Saturday around 7:30 p.m. Eastern Standard Time. I know the US is now stopping daylight saving tonight. So next Saturday, it'll be 6:30 p.m. Eastern Standard Time, which will be 3:30 Pacific Time next Saturday. It's 10:30 for me here on a Sunday in Sydney, Melbourne. I do this every week. Again, 10:30 a.m. Sunday, Sydney, Melbourne time, 6:30 next week p.m. Eastern Standard Time on a Saturday in the US, 3:30 p.m. Pacific Time in the US. And I'll see you all again next week. Now, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. We also have a membership for families of critically ill patients in intensive care. You can go to intensivecarehotline.com, go to the membership area there, or you can go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also offer one-on-one consulting over the phone via Skype, Zoom, WhatsApp, and I talk to doctors and nurses directly. I represent you in family meetings with the doctors and nurses, and I answer all the questions. I ask all the questions you haven't even considered asking, and I help you to make informed decisions, get peace of mind, control power, and influence fast. We also offer medical record reviews in real time so that you can get a second opinion in real time, and we also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Thanks again for watching. Like the video, comment below, share the video with your friends and families, and I'll talk to you again during the week in my quick tip videos or next week again on the live show. Thanks for watching. Thanks for your support. This is Patrik Hutzel from intensivecarehotline.com, and I will talk to you in a few days. Take care for now.